some kind of dictatorship of this kind of evidence-based medicine? And is there time to move on? And is there, as a historian, have you got an idea to what we could move on to?
Again, we're being asked to predict the future. Well, I think perhaps to develop a greater understanding that evidence is, evidence isn't the kind of value-free entity that we're presented as, because the evidence-based model is used very much as a mantra now, isn't it? Something is evidence-based, so it's incontrovertible, but nobody really questions exactly what that evidence is and who's supporting that evidence and who isn't, and so on. So the interconnection between evidence and policy making with a small p, not necessarily political policy making, I think is one that's not very much, assessed or taken on board.
Okay, my presentation sort of moves on quite nicely from yours and from the discussion as it happens. So I suggest that I'll make it briefly, and then we can move the discussion forwards. I just want to start by saying where I'm coming from. I'm a public health physician who actually works within the university and NHS system in terms of the formulation and development of direction of health policies, particularly around prevention. And what I'm going to do is just talk a little bit about the economics of evidence and the nature of science. I think Virginia has really talked about interests in some of the sort of sociology of evidence, and I'm going to try and talk a little bit about the economics. And I became interested in it because working across the health service and looking at primary care trusts and people that are commissioning services left, right and centre, an overwhelming predominance of treatment and sort of therapeutic interventions well downstream in people's developments of the chronic disease, and virtually no investment in the prevention of those diseases at the population level, particularly where it came to anything around modification of lifestyle. So I was sort of challenged with trying to understand where that was, and I think that some of the arguments about why we don't really look at preventive and invest as much in preventive medicine as we might actually apply very much to the area of complementary alternative and traditional medicine as well. The complementary alternative traditional medicine has come under a lot of pressure over the last few years to provide evidence of its effectiveness, and this has come from a number of sources. I think the hegemony of evidence-based medicine being one reason, but there's been European-wide moves to standardise regulatory structures, and the activity of the witch-finding bad science bloggers who would be very much in evidence and command very great support from a large number of people in the scientific community, and probably would be a good subject for a PhD in themselves. Actually, how their social role plays out, but they've pursued an almost Dawkins-esque crusade against most treatment and health interventions which are not grounded in a dominant scientific materialist ontology, and some which are, such as dietary supplements and functional foods. Given the ascendancy of evidence-based medicine, and in particular the development of large randomised controlled trials as a gold standard for the measurement of efficacy, and the development of the National Institute for Clinical Excellence as a sort of gatekeeper which uses cost-utility frameworks to determine whether treatments should be available in the NHS, I think this has created an important driver. Because if evidence drives policy, which in turn leads to the large-scale deployment of health resources, as many of us agree that it should, then decisions about the allocations of research budgets are going to drive the accumulation of evidence, thence policy downstream. So let's look at some facts about UK health research spend. Public sector in the UK, the MRC and the NIHR spent 1.3 billion on health research in 2007. Medical research charities 0.8 billion. The UK biotech and pharmaceutical industry 8 billion, of which 75% was accounted for by two companies, AstraZeneca and GSK. Companies spending greater than that amount also on promotion, drug promotion and communication campaigns. Second point, bringing a new drug to market for a single indication costs about 550 million and takes 10 to 12 years. Third piece of information, the key policy document in relation to health research in the UK was a document called the Cooksey Report, which was commissioned not by the Department of Health but by the Treasury from a biotech entrepreneur called David Cooksey. It was published in 2007. The basic and core analysis of this report was that if UK PLC, the UK economy, is going to compete over the coming period for its share of global GDP in the face of the rise of the economies of China and India in particular, then the biotech and pharmaceutical sectors are going to be crucial in maintaining that, in maintaining the UK's share of global GDP. The NIHR, which is the National Institutes of Health Research, which takes overall responsibility for health research in the UK, has a mission which has now stated, a vision I should say as such, to increase the health and the wealth of the nation through research. Currently, the lion's share of NIHR funding, about 50%, that's 400 million in 2008-9, was spent on infrastructure projects, which was about building product delivery and trialling pipelines into the NHS, therefore providing an infrastructure and service in support of the development of compounds and molecules produced in the UK biotech sector. Now, the NHS evidence website suggests that complementary and alternative medicine research is about 0.01% of the total spend in the UK, and that complementary medicine is about 0.1% of NHS spend. So let's assume that that on average, that biopharmaceutical treatments are more effective than complementary and alternative medicine treatments in 90% of cases. 90% of cases. But costs on average are the same, and that both biopharmaceutical and complementary alternative medicine treatments are available for all conditions. Let's further assume that the distribution of total treatments reflects the availability of adequate evidence for effectiveness and the marginal cost effectiveness, which is the rational resource allocation model used by NICE. Now, if we spend 1,000 times as much money on biopharmaceutical research that we do on complementary and alternative medicine research, we might expect to have it's 1,000 times more likely that we would have evidence of effectiveness. So for the 10% of conditions in our hypothetical situation where CAM might be more effective, we'd expect to have evidence of this in only about 1% of the cases where it was actually more effective. So a resource allocation model based on a cost-utility analysis would therefore lead to a large skewing in the allocation of resource to biopharmaceutical interventions. If we made more realistic assumptions about the sort of thresholds of evidence which need to be achieved for it to become acceptable, then the skew would be even greater.